I'll present this topic. So before going to this topic, I think already we have spoken we have discussed in 3 topics before. So even about our topics, everyone can hear, right?
Yes, Bina, continue.
Yeah.
I can hear you well, Bina. Yes, go ahead.
Yeah. So like so today's main objective, I have put only 3 are there. So first, what is preparative regimen, why we are giving, and how many protocols we have recently we are using in our setup, and the preparative regimen how many preparative regimen. So we'll discuss a little bit briefly on that. So first, preparative regimen, it's a treatment which is given to the patients to prepare their body to receive bone marrow or stem cells. Like its main goal is to eradicate all the underlying disease and provide enough enough immunosuppression to facilitate engraft in the case of allogenic BMT. And we know, for our patients we are giving first conditioned regimen, then we'll give conditioned regimen to prepare the body, and after that we'll give a bone marrow harvest or bone marrow or stem cells we are giving to them. So first, during our journey, we have lots of protocols we have used in our setup. So now it's a 5th generation which we are using now. So there now only for fully matched thalassemia patient we are using only 2 protocols. That is, one is match related for the this severe thalassemia 0.1 or 0.5.1 and 0.5.2 we are using. That for first is who is having normal spleen and liver, and second 0.5.2 which we are using for splenomegaly and hepatomegaly. So this for high risk patient there. So 5.2 is we are using for high. So first we'll discuss about the low risk and fully matched thalassemia patient. So this first will give fludarabine dose 180 mg per meter square for 6 days. That is 30 mg per meter square per day will give. And the ATG, that is an antithymocyte globin ravid, that is 4 mg per kg we are giving, and for 3 days. And tab busulfan we will give 14 mg per kg for 4 days, and cyclophosphamide will give 200 mg per kg for 4 days. And rest day will give a marrow, and for donor we used to give injection GCSF on day -5. We'll start for 5 days. So this is the in first point 1 we are giving. And cyclosporine 20 mg per kg per day, that is per oral. On day -2 we'll start, and we'll check a label. On the basis of that label we'll adjust the dose of the CSA label. And methotrexate will give 10 mg per meter square at day +1. Then 8 mg per meter square will reduce the dose. The day +3 and day +6 we use we used to give this. So this is the protocol first which we are using for our patients currently. And this is the protocol 2, that is 0.5.2, that which we are using for the high risk patient and splenomegaly patient and hepatomegaly patient. So this is fludarabine we are giving same dose 180 mg per meter square, that is for 6 days. And ATG in this only ATG is difference. And in low risk patient we are giving 4 mg per kg, and here ATG we are giving 5.5 mg per kg for 3 days. And busulfan same dose 14 mg per kg for 4 days we are giving, and cyclophosphamide 200 mg per kg for 4 days. So same thing, cyclosporine also 20 mg per kg. Loading dose will start on day -2, and like after on day +2, we'll just check a label and adjust with that only. And methotrexate same, like first plus day +1, like we'll give 10 mg per meter square, and like after day +3 and day +6, we'll reduce the dose, and 8 mg per meter square we used to give. So these are the two protocols which we are using for match related donor for thalassemia patient. This protocol we are we are using. So this one is the partially match related um, patient we are using for severe plastic anemia, which we are using 0.2 protocol. That is, in these protocols we are using ATJ 7 mg per kg and fludarabine 180 mg per meter square, and cyclophosphamide this 15 mg per this actually 15 mg per kg per day dose, and TBI used to give, and rituximab for this patient on day -1, and TBI used to give day -2. And for GCSF, prime marrow will infuse that. For donor, like we used to give GCSF on day -5, we'll give 5 days of GCSF to donor. And cyclophosphamide after like post transplant, we used to give we are giving that 30 mg per kg per day, that is on day +3 and day +4. And for this partially match related donor, we are starting cyclosporine on day +5, that is like 10 mg per kg per dose twice a day. And day plus on 7, we used to like check a label and adjust with that only. After 2 days, like we'll just check a labels and we'll adjust the dose for that. And MMF also will start, that is 10 mg per kg per dose, like TDS 3 times a day, like till will continue to day +90. So this is the partially matched.
Dina, sorry, I interrupt you because I think here yeah, you sent me the slide, but I missed this. So normally cyclophos, so here we're talking about partially matched related transplant,
Yes,
it's also called haploidentical transplant. So we normally use 30 milligram per kilo per day only for Fanconi anemia, which of course can be a form of severe aplastic anemia, but normally we use 100 milligrams. So this is a mixture because if we use, if it's a Fanconi anemia, we can only give a maximum of 60 milligram per kilo of cyclophosphamide. And so this would be the protocol for severe aplastic anemia, which is non-Fanconi, and the cyclophosphamide would be 50 milligrams per kilo per day times 2. So the total dose would be 100 milligrams. So I'm just pointing out the fact that we normally use 50 times 2, which is 100 milligram, and we use 60 milligram per kilo total dose only in Fanconi anemia because they are more sensitive to cyclophosphamide. Okay,
yes,
thank you.
Yes, so yeah, so this is match related donor for severe aplastic anemia. This is the protocol which we are using for the match related donor for the severe aplastic anemia, that is 0.3.2. So in this, like ATZ, we are giving 5.5 mg per kg. That is on like for 3 days we'll give, and fludarabine 30 mg per meter square per day. That is like it will come 180 mg per meter square for 6 days, and cyclophosphamide, that same thing, 120 mg per kg for like 4 days. And sorry, and like on day 0, we'll give a marrow, like GCSF prime marrow. And CSA, like same thing, like 20 mg per kg per day will give like will start from day -2 and we'll check a level on day +2 and we'll adjust levels with the like level it will come like that, will adjust it. And methotrexate same thing, and like 10 mg per meter square, like first we'll give on day +1 and so we'll reduce the dose 8 mg per meter square on day +3 and day +6. So this one is the match related donor for the severe plastic anemia, that is 03.2 which we are using. And this one is the like partially match related donor for severe thalassemia and like which we are using 06.2. And for this like DSA these sensitizations like we are doing now. So this is actually like first we are starting for this our patient, one patient it came. So recently this protocol it has been created, so before it was not there. So first botrima and retox we are giving, and fludex 2 cycle, and will increase like so ATZ like fludarabine, ATZ, busulfan, thiotepa, and cyclophosphamide like we are using in these protocols. So first like fludarabine will give for like 2 cycles, that is 200 mg per meter square, and dexamethasone 125 mg per meter square for 5 days, and botrimazib 1.3 mg per meter square for 4 days. And retox like 2 days will give 375 mg per meter square, and ATZ we are using 7 mg per kg, that is for 3 days. And fludarabine, that is 180 mg per meter square, that is when like condition regimen it will start, that time like for 6 days we are using that 30 mg per meter square per day. And busulfan 14 mg per kg, so for 4 days. And thiotepa on day -3 8 mg per kg. Sorry.
Bina, I just want, yeah, sorry, I interrupt you. I just want to, because otherwise it becomes complicated. So I just wanted to mention that bortezomib is a drug that is used for multiple myeloma, which is a sort of low-grade leukemia, which is seen in elderly people, and it specifically inhibits cells that produce antibodies, because this multiple myeloma is typically a leukemia of cells that produce antibody, of plasma cells. And rituximab, and so bortezomib is a drug, is not a monoclonal antibody, while rituximab is an antibody against B cells. So those are given, as you said, when we have a problem with donor-specific antibodies. In other words, the recipient has antibodies against the donor, and that increases the chance of rejection. So with these two drugs, we try to decrease the production of donor-specific antibodies. I think we actually used it only recently for the first time.
Yes, yeah, recently, yes.
Yeah. Okay. Sorry. Go ahead, Bina.
Yeah, thank you, sir. So now like all these like we have discussed about the protocols which currently we are using for our patients. So now next is preparative regimen. So like I have took like important like which we are using. So we'll discuss about the fludarabine first. It's a chemotherapeutic agent like which like we are using for the treating hematology malignancy. And first main action of fludarabine is to purine of analog and the metabolite that it will inhibit the DNA synthesis. So main like action of fludarabine is like it will inhibit all the DNA synthesis. so in patient's body. And main side effect, like commonly we are not seeing for our patients, but like it's main common side effects of the food ravens are like common, the nausea, vomiting. Sometimes they will have a diarrhea, headache, and sometimes like tiredness, loss of appetite, sore in the mouth, and like some pain they will have, and itchy, some rashes it will be there. So, and doses like which we are using in our like BMT already, like we have discussed in a protocols. So mass related donor, like we'll give like we'll use 180 mg per meter square for 6 days, and the partially macerated donor, like first 2 cycles will use 200 mg per meter square 5 days, and the conditioned regimen 180 mg per meter square we used to give. So these like usually we are infusing for over 2 hours, and we'll watch for the like side effects, if anything, like as per side effects, symptomatic like treatment we'll give to our patients. So next is the ATZ. So ATZ, the main action of this ATZ is like it will act against the human T cells and their precursor, that is like thymocyte. Like we are using this. Anything, sir? You are asking?
No, Bina, there's somebody who has the microphone on. Maybe, so everybody else, there is no Bina. Can you please switch off your microphone? Ajit, I think you have your microphone on as well as the camera. Go ahead, Bina.
Okay, so but like this ATZ, like we are using to prevent and the treat of acute like rejection of the like transplant, like even like this ATZ they are using on the organ transplant also, and like we are using for our bone marrow transplant. So main side effects of this ATZ is like chills, low levels of white cells. Main reason, like main side effects are chills, like fever, like they will have a rashes in their body, and like nausea, shortness of breathing they will have, and sometimes they will have a like high blood pressure, muscles pain due to fever, insomnia, rashes, sweating, and general feeling of unwell because of fevers and all. So, and like doses like already like I have mentioned in a protocol, so already I'll explain here. So on full mass related donor we are using 4 mg per kg, and for the high risk 5.5 mg per kg we are using for the patient ATZ. And like for infusion, like 5 to 8 hours we are infusing. So before giving these medicines we are pre-medicate first the patient with the paracetamol, hydrocodone, and chlorophenamine, ondansetron, as per like their side effects. And after that, like gradually we'll increase the flow rate of the ATZ. So, and we'll watch for the like side effects, like of course it's antibody, so it will react, antigen antibody, it will react, so it will release the cytokinase. Because of that, like all the effects it will be there. We'll expect the fever and the chills and rashes. So as per there, like a symptomatic treatment will give to reduce that. And main thing is in ATZ, like we'll watch for like it's expected fever and rashes. So like every patients they will get, sometimes there will be more reaction, sometimes they will have a shortness of breathing, like maybe desaturation, and the high like tachycardia, everything it will be there. So busulfan, it's a myeloablative drug which we are using in our setup in hematopoietic cell transplant. So main effect of busulfan is like to destroy all like and to destroy and wash out of the bone marrow in our patient's body. And the main side effect of this busulfan is like nausea, vomiting, diarrhea. They will have constipation, loss of appetite, and even dizziness, abdominal pain, darkening of this skin color and fatigue they will feel. So these are the side effects main. And during this time, we are giving. Now we have started. Before we are giving lorazepam to prevent this effect of busulfan, but now we have started levopril, the levocitram, for our patients. Like we'll start from during the ATZ last dose. After that, to reduce the side effect of busulfan.
Yes, Bina. So
And like doses,
the
like
main
we are
side
using
effect.
all the.
Bina,
Yes, sir.
sorry to interrupt you. Yes, we're giving levetiracetam, and before we're giving lorazepam because busulfan can cause seizures. Now, we have never seen, I think, seizures during busulfan because, right, we give the medication to prevent that, but one of the main side effects of busulfan are seizures, and that's why we
Yes.
give those drugs. Yes.
Yes, sir. And because of lorazepam, actually, lots of patients they are getting mood swings, so we have changed to levopril. Is that right, sir?
Yes,
Hello?
Bina. Yes, that's correct. Go ahead. Yes.
Yes, sir. So for all the protocols, we are using the busulfan 14 mg per kg. That is like, or and currently we are using 14 mg per kg for all the protocols. And cyclophosphamide, it's a this is also the chemotherapeutic drug, like which like it works by this slowing and the stopping of cell growth, like fast multiplication of cells in our body, that it will stop replicating that. And cyclophosphamide also work by the decreasing your immune system response to the various diseases. So that's why like we are giving an our uh, to our patients. And the main side effects of this is like low white blood cells counts and loss of appetite, hair loss, bleeding from the bladder, that is hemorrhagic cystitis they will have. And other side effects are increased risks of cancer, infertility in the male, and allergies reaction, and the pulmonary fibrosis. So main during the cyclophosphamide to prevent the side effect, that is like bleeding from the bladder, that is hemorrhagic cystitis, so inflammation of bladder. So to reduce the effect of that, like we are giving injection mesna 24-hour and double hydration. And during that during cyclophosphamide we used to give. And the main dose is 200 mg per kg we are using for like fully matched patient. And for this, like main instruction, like we like cyclophosphamide will give like over 1 hour, and plus actually I haven't added over here, so we'll give a double hydration from like IV also, and we'll instruct patient also to give hydrate, like hydrate more. And even like we are giving lasix to it should not overload in their body. And we'll watch for the like we'll strictly maintain the IO chart. And even like we'll check a weight if it's any variation, if in IO chart also if any variation, and with the weight gain. So like we'll give a diuretics to maintain that thing. And we'll like explain to mother also, like during this time they will have like a more frequency of urination will be there, and they have to hydrate properly to the child. So rituximab, it's a medication like which we are using like for the certain autoimmune disease and type of cancer. And like mainly this medicine we use to destroy the B cells. It can also the like immunosuppression medication. So the main side effects of these medicines is like fever, rigor, and chills that occur like first time of the administration. After that, like when we'll uh, in second or third dose, like there will be the less side effects in patients. And doses we are giving 200 mg per meter square. But here like now we are giving 375 mg per meter square. I think I'm not misleading, right, sir?
I'm sorry, Bina, what did you say?
So doses of rituximab now it's a 375 mg per meter square we are using.
Yeah. Yes.
Yes, yes, sir. So before actually 200 mg per meter square, like we used to give it, but now 375 mg per mg per meter square we are using. So these the main instruction during the rituximab, like we'll pre-medicate the patient with the paracetamol, chlorophenamine, and plus with the understerone. So and after pre-medication, so we'll infuse the rituximab and 30 minutes gradually will increase, and it's supposed to finish within like 4 to 5 hours.
Bina, just one correction. Like regular protocol, we are giving 200 mg per meter square.
Yes.
So post
Yes.
transplant, if they come with the autoimmune disorders, that time we are giving 375 mg per meter square. In the regular protocols, we are giving 200 mg per meter square. Rituximab.
Okay.
Yes, Bina. Now, of course, we don't want to make this too complicated, but yes, Sandeep is right. Now, we may be using Ultros 375 in patients that have donor-specific antibodies before transplant. So, because otherwise we give a lower dose as a standard in a partially matched transplant to prevent to decrease the chance of rejection, and also rituximab may decrease the chance of graft versus host disease because B cells are also involved. They are antigen presenting cells, and they may be involved in triggering graft versus host disease. That's why we use, as Sandeep said, different doses depending. So routinely we would use 200, but if we have to fight the presence of antibodies like donor-specific antibodies or anti-red cells antibodies after transplant, then we would use 375. Yes.
Yes, sir.
Okay.
Thank you, sir.
You're welcome.
So another medicines I have took is Thiotipa, mostly like we are using for as a chemotherapeutic agent for our patients. So these are like mainly we are using these medicines to read it's like anti-cancer drugs. So it's an anti-neoplastic and like cytotoxic for this. So mainly like we are using for the our patients like who is having, I think only mostly we have used only one time, yes, one time only we have used this patient. So this can be also we are using with or without like total body irradiation as a conditioned treatment for our like prior allogenic or autologous hemopoietic progenitor cell transplantation in hematological disease, like for like children's and adults both. So this, and the main side effects of Thiotipa is it will suppress the bone marrow, resulting in leukopenia and thrombocytopenia and anemia. So and it's a toxicity of the liver and the lungs may also occur. So the dose we are using is 8 mg per kg in 2 doses we are using Thiotipa.
Yes, Bina, let me just ask quickly. So Thiotipa is a pretty toxic drug, is also quite expensive, and is both immunosuppressive and myeloablative. The reason why we try to stay away from it and not use it is because, of course, sometimes we add it, especially in haploidentical partially matched transplant, because it does decrease the risk of rejection. But the combination of busulfan and Thiotipa, as opposed to only busulfan as myeloablative agents, will, so the combination, the addition of Thiotipa will increase substantially, as far as we know, the risk of infertility. So almost all children who receive a combination of busulfan and Thiotipa will be infertile. And of course, it's a very effective agent, but it's toxic acutely and also in terms of fertility.
Yes, sir.
Okay.
Addition one point suggest I want to add, Bina, like about nursing care. During somebody getting theotypa, that usually the theotypa will be exit from the skin. So they have to get the skin care is very important. They have to get the bath, like at least twice a day. We will give the sponge bath for them, and skin care is important during theotypa.
Yes, sir. So next is total body irradiation. It's also a form of radiotherapy, like which we are using as a primary for the preparative regimen for our bone marrow transplantation. So it's a setting of bone marrow transplant severe to destroy or suppress the recipient immune system and preventing immunologic rejection of the transplanted donor bone marrow or bone blood stem cells. Additionally, like high dose of total body irradiation can eradicate residual cancer cells in the transplant recipient and increase the likelihood that transplant will be successful. So that's what we are using here. So, and the main like doses of total body irradiation used in bone marrow transplantation is like it should be typically from 10 to 12 gamma rays. So and the main side effects of this is like it will suppress the bone marrow, that is low blood counts will be there, and like some patient they will have this fatigue, skin reaction, and headache, nausea, vomiting, they will like get it.
Pina, let me add very quickly. So
Yes,
GY stands for, it's an abbreviation for gray, which is the name of a person. And normally we measure it in centigrades that used to also be called rads. So 10 to 12 grays is the dose that is normally used in leukemias, for example. But when we use it only for, or mostly for immunosuppressive purposes, although it is also myeloablative, we use it at doses of 200 to 400 centigrades. These, so this is just to clarify. So GY stands for gray, and normally often centigrade is the unit measure that is used. And most often we don't use 10 to 12 grays because we don't deal most of the time with leukemias, but we use more like 2 to 4 grays, which is 200 to 400 centigrades. Okay, I know, Bina, this is a bit of a complicated topic, but don't worry, you're doing great.
yes. So yeah, this much like